नमस्कार दोस्तों, my name is Kamal Yadav. Welcome back to the coding related questions, interview questions part 2. Today we will discuss about the questions that will be asked most commonly in the coding. So let's start this video and we'll discuss that how many compartment in a knee, right? So you will be able to see that how many compartments are in knee. Question is that what is the arthroscopy? So in one line answer is there. One line answer is there. The knee has three arthroscopic compartment: medial, lateral, patellofemoral. Coding depends on whether procedure are performed in the same or different compartments. So there are three compartments in a knee, that is the medial, lateral and patellofemoral. So you will able to see in this video like this. There are three compartment is here. We'll discuss in detail. If you are like this video, please subscribe. You are learning coding with a Kamal. Here is a clear interview ready explanation of a knee orthoscopic components with names, coding related relevant example. This topic is a very commonly asked in the orthopedic or outpatient same day surgery. In a medical coding interview, there are three main compartments of the knee evaluated during the orthoscopy. Names of knee compartment is the medial compartments include the medial femoral condyle, medial tibial patello and medial meniscus. Common condition is there, some diagnosis and condition is coming: medial meniscus tear, medial compartment osteoarthritis. So these are conditions happen into the medial compartment. So you will see here coding related some procedure CPT 29881 arthroscopy knee surgical with meniscectomy medial or lateral. So here given is or, it means that either medial or lateral. So we need to focus there which compartment is performed. Lateral compartment include lateral femoral condyle, lateral tibial patello, lateral meniscus. Common diseases or conditions are there: lateral meniscus tear, chondral defects. So two conditions are mainly affect the lateral compartments. Others conditions also affect, but what are common that is here. Example na 29881 meniscectomy of lateral meniscus. So this is an example of the if lateral meniscus is repair like perform, that time we are using 29881. Important interview points: we are checking medial and lateral meniscectomy are not coded separately, same CPT, right? That will be not coded separately. Patellofemorals, we have another compartment of knee includes the patella, that is called the kneecap, trochlear groove of femur. Common condition that affect the patellofemoral compartment, that is the chondromalacia patella, patellofemoral arthritis, right? So example of CPT that is performed into the patellofemoral compartment, that is CPT code is 29877 orthoscopic chondroplasty of patello or femoral condyles. Let's see that the like abbreviation you will be able to see here. Quick review: interview tables, compartment, key structures, common procedures. Medial medial meniscus repair are performed. So that time we are using procedure perform meniscectomy. So we have a code for that. Lateral meniscus. So meniscectomy is performed. Patellofemoral, so patello and trochlear, here procedure is performed chondroplasty, right? Important coding interview rules. What is asking? They are asking meniscectomy. Meniscectomy, how they perform like that: medial or lateral, same CPT code 29881. Both compartment treated, still one unit only. For example, medial or laterals, both compartment treated, that time we are using one unit only. Chondroplasty, separate compartment allowed, like one procedure perform in the like a medial, another is performed lateral, that time we can code that. Medial compartment chondroplasty code is 29877. Patellofemoral chondroplasty is code is at 29877. Different compartments billable separately with modifier 59 or XU modifier if payers allow, right? Payers depends upon the insurance or payer guidelines, we are following that. Interview example scenario: procedure performed, medial meniscectomy, patellochondryloplasty. Coding, how you will code that: 29881 meniscectomy, 29877 with 59 modifier, chondroplasty, separate compartment. Because of separate compartment here, patellochondroplasty, so that's why they coded both procedure. Okay. Common interview questions: how many compartments are evaluated during knee orthoplasty? There are three: medial, lateral, or patellofemorals. Below is a clear interview ready explanations of bundling rules CPT 29877, 29811, and 29880, written exactly the way orthopedic or medical coding interviewers expected. I have added NCCI logic example because this topic is frequently tested. CPT code 29877, description is there: orthoscopic chondroplasty, debridement of articular cartilage. 29811, orthoscopic meniscectomy, medial or laterals. 29880, orthoscopic meniscectomy, medial and lateral, right? So core bundling rule or golden interview rules, we can told that chondroplasty 29877 is a bundle into the meniscectomy 29880 or 29881 when the performed in the same compartment. Separate compartments equal to potentially separate reportable, right? So let's see, bundling matrix or easy to memorize. Primary procedure 29881 along with CPT 29887, same compartment, bundled, right? 29877 different compartments, separate billable with modifier 59 or XU, like not used. Bundle, like usually bundle, no separate compartment left, right? So these codes and this compare is given, you can check that detailed explanation by the coders. 29811 plus 29877, same compartment, bundle. Example: medial meniscectomy or medial femoral condyle chondroplasty, both will be not coded together. Coding only 29881 only, not code 29877, not separately reportable. Reason: same compartment, NCCI bundling showing. Different compartment, separate billable. Example: medial meniscectomy, patellochondroplasty. Coding 29881, 29877 with a 59 modifier or XU. Reason: separate anatomical compartment. Third example is there: 29880 plus 2988877, almost always bundle. Why 2980 already include both medial and lateral compartment? Chondroplasty is considered as a incidental, so we can't code together. Next example: medial lateral meniscectomy and patellochondroplasty. Coding 29880 only. Most pair do not allow 29877 separately with 29880. So please take care of this. 29880 versus 29881. Important interview rules. Scenario: medial meniscectomy only, 29881. Lateral meniscectomy only, 29881. Medial plus lateral meniscectomy, code is there 29880. Both compartment, but two units of 2 units of the 29881, like incorrect. NCCI and modifier rules interview favorites. Modifier 59, different compartment. XU, unusual on overlapping services. So you will able to see NCCI edit and modifier rules interview favorites. When modifier used, or what is the modifier? XU, different compartment. When a different compartment is performed, that time we are using 59 modifier. XU only for the like unusual overlapping services. This is used when the Medicare providers, like that time they are not accepting 59, that time we are use the same purpose. XU, LT and RT not used for knee compartment. Never use modifier 59 for the same compartment services. Please take care. Quick interview questions, we are focusing on that quick interview questions, right? So you will be able to see that. Scenario 1, procedure: lateral meniscectomy, lateral tibial chondroplasty, code only 29881 only, right? Scenario second, medial meniscectomy, partial chondroplasty, sorry, patellar chondroplasty, that time use 29881 CPT, 2988 298779. So you will be code both. Scenario 3, like procedure: medial plus lateral meniscectomy, any chondroplasty, code only 29880 only. Like one line answer is there. CPT, you will able to see that CPT 29877 is bundled with 29880 and 29881 when performed in the same compartment. It may be separately reported with 29881 using modifier 59 only when performed in the different knee compartment. It is generally not separately reportable with 29880. So please take care of this. Memory tricks. What is the memory tricks? We can take a 29811 plus other compartment possible 29877. 29880 everything's bundle. Same compartment, no CPT use 29877. So this is the trick which is helping to remember the things. Next question is there: for the excision of lesion, how many types of closures or repairs are given in CPT book integumentary section? Please named and what a and define the what a complex repair. One line question here, one line answer. Right, CPT recognizes the three types of the closure, that is simple, intermediate and complex. Complex closure involves the extensive undermining, scar revision, debridement, or advanced techniques beyond layer closure. For the extension of lesion, how many types of the closure repairs are given in the CPT book in the integumentary integumentary sections? We have a questions: what are complex closure, simple, intermediate and complex? You are able to see this. Let's discuss these points. This is a very common integumentary interview questions below a clear exam and a interview ready explanation exactly as expected from the medical coder. For the excision of lesion, types of the closure in this CPT section, closure repairs and classified into three types, total three types of the closure. You can told that three types of the closure: simple repair, definition is said, superficial closure, involves epidermis plus dermis, no significant debridement, or layered closed. Layered closed means two layers or more layers. Examples is here simple sutures, staples, tissue adhesive. Example is given derma bond. Coding rule is saying include the bundle, included or bundle in a excision codes, not report separately. Intermediate repair definition is said layered closure of subcutaneous tissue or superficial fascia, or single layered closure with extensive cleaning or debridement. In this situation we are considering as an intermediate repair. Examples: deep suture plus skin sutures, right? Closure after removal of contaminated tissue. You will able to see that. Coding rules is here include bundles in excision, not separate reportable. Intermediate, like we have already discussed this. Layered closure of the subcutaneous plus superficial single layer with a closure, extensive cleaning and debridement. Example: deep suture skin sutures, closure after removal of the contaminated tissues. Rule is here may be reported separately if documented. Use repair CPT code 120312120057. Complex repair definition. CPT very important interview questions. It is like when you will see that a complex repair include one or more of the following: extensive underminings, stents or retention of sutures, revision of scar, debridement not part of excision, creation of the defected or for repair, complex layer closures. These are all points we need to check that. Next question, part of that: what is the complex closure? Direct interview questions. One line definition: a complex closure involves more than a layered closure and include the extensive undermining, scar revision, debridement techniques required to additional skill and time. Example of complex repair, let's see that: excision of fascia lesion requires extensive undermining to reduce tension, multiple deep layer closed. Complex repair example is a two like old scar reversed, tissue rearranged, deep and superficial layer closed. Complex repair. Coding rules for the complex repair here: bundling. Simple repair is always bundle. Please remember, separately billable. Intermediate and complex repair may be built separately. Measurement based on the length of repair wound, anatomical area, face, neck, trunk, extremity have a different code, so please focus on that. Face, neck, trunk, extremity having a different code range. As per size we are coding. CPT repairs code range helpful for the interview. Simple 1200121221. Intermediate repair code ranges of 120312120057. Complex repair 131002136160. These are the code range we should be remember. Quick interview table: simple repair layered close, no. Intermediate repair layered close, yes. Complex repair layered close, yes. Special technique, no. Separately billable, no. Like intermediate, minimal. Special technique, minimal. Separatable billable, yes. Like that complex, extensive or separately billables. Common questions asked in an interview: is layered closure always complex? Answer is no. Layered closures alone is a intermediate, not a complex. Next question is coming here. You will be see that what is the difference between the segmental and non-segmental spinal instrumentation? So one line interview questions. Let's see. Non-instrumental spinal instrumentation involves fixation at only two vertebral segment, where the segmental instrumentation involves the fixation at three or more vertebrae with hardware placed at each level. So please remember, non-segmental spinal instrumentation involves fixation at only two vertebral segment, whereas segmental instrumentation involves the fixation at a three or more vertebrae with a hardware placed at the each levels. So you will be see here segmental segmental instrumentation example is given, non-segmental instrumentation example is given. So I believe that this picture is clear for that. This is a very common orthopedic spine coding interview questions. Below is a clear CPT focus explanation with a difference or difference definition and example exactly the interview expected. What is the spinal instrumentation? Spinal instrumentation is referred to implant used or stabilize the spine such as rods, screw, hooks, wires, plates. These are reported add-on CPT code 22840 to 22848. This is a code range where we are using the instrumentation as per the position like anterior, posterior, segment, non-segment. So we having code segment versus non-segment in a spinal instrumentations. Non-segmental spinal instrumentation definition. Non-instrumentation like instrumentation attest only attest at only two vertebral segment regardless of the numbers of the screw or hooks. Fixation is placed only at the top and bottoms of the construct, no fixation at the intermediate vertebra. Key interview points: always two vertebra segment only. So in non-segmented, always two vertebra. Example given: 22840 posterior non-segmental instrumentation. Example there: pedicle screw and two vertebrae. Clinical example is here: fusion of the L4 to L5. Screw placed only at L4 and L5. No screw at the others levels. That time we are feeling non-segmental instrumentation. Segmental spinal instrumentations definitional instrumentations attached to the three or more vertebral segment with fixation at each segment. Screw hooks placed at the every vertebral level. Previous strong stabilize stabilization. Key interview points: three or more vertebral involved. Example is given: CPT 22842 posterior segmental instrumentation 3 to 6 vertebral segment. CPT 22843 posterior segmental instrumentation 7 to 12 segments. Clinical example: fusion from the L3 to S1, screw placed at the L3, L4, L5 and S1. So in this way segmental instrumentation is there. Comparison table for the interview purpose. Let's see features: non-segmental or segmental. Vertebral segment exactly two, segmental three or more. Fixation point: top and bottom only at each segment. In a segment, at each segment. Stability in a like non-segmental less, segmental is a more. CPT example 22840. Here CPT example is 22842 or 22843. Coding rules: add-on code. So common interview questions and answer: if a screw are placed at L4 and L5 only, is it segmental? Answer is no. Only two vertebra, non-segmental. If fusion is a L4 to S1 but a screw placed at L4, L5 and S5 S1, then segmental instrumentation. Vertebra, three vertebrae. Okay, let's start into the another slide. So memory trick is a easy recall. How to easy recall? Two vertebra non-segmental, three or more vertebral segmental. So what is the difference between the like non-segmental segmental? It is a simple, right? You can give example. Next question is coming: what are the two components of radiology codes? What are two components of the radiology codes? Question is here. You will be able to see that professional component and technical component. You are learning coding with a Kamal. My channel name is Kamal Yadav Mahal. कमल यादव महल कोडिंग चैनल में आपका स्वागत है. You will be see that the all video one line interview questions. What is the question is there? What is the two components of the radiology code? One line interview question is the radiology CPT codes having a two components: technical components which cover the equipment and performance of the study, and the professional component which cover the physician interpretation and reporting. Let's discuss into the details. This is a very common radiological medical coding interview questions. Below the clear CPD based explanation with example exactly how interviewers expected from the coders. Two components of the radiology codes as we discussed, that the technical components and professional component. Technical components, we are saying that PC modifiers and PC 26 modifiers. Like here modifiers is used. Technical component is a TC. What is the include? Use equipment, machine, supplies and contrast, technology, work, facility, overhead, basically how the test is performed. These all points are part of the technical components. Modifier use TC modifier, already I told that. Example here, x-ray to view, CPT code 71046 TC, chest x-ray, whatever. So what I chest x-ray to view is performed, CPT code is a 71046 with a TC, billed by the hospital or imaging center, right? So they are billing with the TC modifier. Professional component, this is the what is the include. You will be able to see that what is include: physician interpretations, written radiological report, medical decision making. These all 3 points is a part of the professional component, basically reading and reporting the study. Modifier used, 26 modifier we are using for the technical components. Example is here, chest x-ray interpretation, CPT code of 71046 with a 26, built by radiologist. Global radiological services, when no modifier is used, like global radiological services when no modifier is used, same provider perform both TC and PC, like that time we are not using any modifier. Example here, CPT like 71046 include the medicines interpretations or machine plus interpretation. That time we are not using. Quick comparison of the table, interview friendly. Components modifiers includes both who bills. These points are here in a headers: technical, professional, global. Modifier is here technical, TC includes equipment, staff, supplies. Who can bill? That is the facility or hospital. Professional component 26, what they will perform: interpretation report, physician, radiologist, doctors, those are bill. Global like that TC or 26 non, they are not bill. That includes TC technical plus professional, both are include. Who can bill? Same entries, like those are like who is a part of the facility, who is a part of the physician, those are. For example, like a physician whose own hospital, that time he can't bill the TC or 26, that is called as a global, right? Let's see important interview rules. 26 modifier, physician work. TC modifier, facility work. Don't append a TC to the codes already technical only, right? Same radiology codes are a PC only, supervision or interpretation. Common interview question: can TC and 26 be billed separately? Yes. When facility and physician are different, that time we will bill both separately. Memory 26 brain or interpretation, when the physician use, that time we are using 26. TC tools or machines or technology use, that time PC is there, so we can easily recognize that. Let's move to the next questions. As per ICD conventions, how will you give the difference between HIV positive and HIV negative? So how can you differentiate? Let's see in a one line interview answer. As per ICD conventions, J21 is used for asymptomatic HIV positive patient, while B20 is used for the patient with the HIV disease or AIDS. Once a patient has a HIV related condition, B20 is used for. You will see in this HIV positive virus but no symptom. That time we are using Z21. Severe symptoms of the opportunistic the infections, that time we are using B20. So you will see that below the clear ICD's convention based explanation of the difference between HIV positive and ends written exactly for the medical coding interviews. ICD-10 CM convention, HIV versus AIDS. ICD-10 HIV infection or AIDS are a closed difference closed are coded differently based on the clinical study, not just a lab positive, right? HIV positive asymptomatic Z-ICD-10 code is here. Z21 asymptomatic human immunodeficiency virus HIV infection status. So we are coding status code. When to use, patient is HIV positive, no HIV related symptoms or conditions, no documentations of HIV defining illness. Important conventions rules: don't use J20 if patient has ever had a HIV related conditions. Example documentation: patient is HIV positive, stable on the ART, no opportunistic infections, code only Z21. Let's second point: AIDS or asymptomatic HIV infection, ICD code B20, human immunodeficiency virus, HIV disease. When to use, patient has an HIV definitions or illness, any HIV related conditions, opportunistic to infections, ICD convention rule. Very important. Once a B20 is assigned, it is used for a life. Never revert to the J21. Common HIV related conditions are like sarcoma, pneumocystis, zerovecalial pneumonia, HIV related dementia, HIV related tuberculosis. These all are examples. HIV related things you will be able to see that here. Documentations: HIV patient with a pneumocystis pneumonia, coding what we can code B20, B59 like pneumocystis pneumonia, we have a separate code. Memory trick is there. Z20 is zero symptom, it means that no symptom. B20 bad complication with the other condition, that time we are code B20 with a complication. Key ICD-10 rules for the interview, you will be see that rule Z21 versus the Z20. Z21 is a asymptomatic, B20 is a symptomatic. Lifetime rules: once B20, always B20. Sequencing: B20 is the code first, followed by the HIV related conditions. Positive test only, do not code the R75. Inconclusive for the confirmed HIV. That time we are using this code. HIV versus AIDS quick comparison tables. Here ICD-10, HIV positive Z21, AIDS B20. Symptoms: no. AIDS symptoms are present. Opportunistics: no. Here in a AIDS, yes. Lifetime coding can change. B20 is a permanent. Sequencing stable, like here standalone. B20 is a first. So this is guideline. Common question in the ask in the interview: if the patient was diagnosed with the AIDS earlier but now asymptomatic, what code should be coded? Answer is B20. Never tell Z21. Okay. Next question is here. You will be able to see that what is the difference between the outpatient consultation and inpatient consultation. One line interview questions. Outpatient consultation is a provided on non-admit patients, while the patient consultation is provided to the an admit patient. Both required a request, reason and report, but Medicare does not recognize the consultation code and instead of use the standard ENM codes as per location, as per setting. So you will be see that outpatient consultation, HIV virus present but no symptom, that person is a consulting with a doctor, that is the outpatient section. You will be able to see that inpatient consultation, severe symptoms and opportunistic infection, that time this is the examples of the inpatient and outpatient. Below is a clear interview ready explanation of the difference between the outpatient consultation and inpatient consultation, definition, CPT, context and the practicals example. This is exactly how it is expected in the medical coding interviews. What is a consultation? Question is coming. Consultation is a service provided by the physician or qualified healthcare professional at the request of another provider to give an opinion, advice, or evaluate and manage the specific problems. There are three R's must be the documented: request for the consult, reason for the consult, report back or requesting provider. So these are three R's are there. Outpatient consultation is their definition: a consultation performed for the patient who is not admitted as a inpatient, seen in the office, clinic, ED, outpatient hospital setting. typically sitting physician office, outpatient department, emergency department. If pair allow, consult. CPT code range is a traditional 99242 99245 for the outpatient. Note: Medicare does not recognize the outpatient code. Consult codes. It is never new or established patient ENM code. So it is use new or established patient ENM codes as per location. Example: outpatient consultation scenario is given. PCP, primary care physician, referred a patient to the cardiologist for the chest pain evaluation. Cardiologist evaluate and send the report back to the PCP. Commercial pair, we are using 99244 outpatient consultation. Diagnosis is here R07.9 for the chest pain. Medicare coding, we are using 99204 new patient office visit. So you will be able to see that what is the differences. Inpatient consultation definition: consultation perform for the patient who is admitted as an inpatient or in observation status or a skilled nursing facility. Typical setting: inpatient hospital, observation unit, a skilled nursing facility. CPT code range: traditional CPT code is used 99252 to 99255. Again, Medicare does not accept inpatient consultation code. Example: inpatient consultation scenario, patient admitted for the pneumonia, infection disease specialist consult. Commercial pair 99253 inpatient consultation, diagnosis J18.9 for the pneumonia. Medicare consultation 99223 initial hospital care. So we are coding like that. Key difference between the comparison tables, you will be see there: features: outpatient consultation, inpatient consultation, patient status not admitted in outpatient, in a admitted, like inpatient in a admit. Location: office, OPD, ED. This is there. Inpatient observation code range here 99242 to 99245. Here code range 99252 to 99255. Medicare acceptance: outpatient consultation not recognized, inpatient consultation code not recognized. So that time we are using outpatient code ENM code, inpatient ENM code. Documentations: 3 hours required, 3 hours required. So we are following this. Important interview rules, very common: consultation must be requested, consultation must be sent report back, transfer of the care. Consultations: Medicare replaced consultation code with the ENM codes, crosswalk codes. We are saying that. Common interview question: does Medicare allow consultation codes? Answer is no. Medicare use new patient, established patient, or initial hospital care code instead of like consultation code. Memory of the trick of memory trick, we can say that OP, office visit not admitted, IP, inpatient admitted, or like that. Medicare no consultation codes. Next question is here: if any physician or same specialty groups physicians is doing consultation more than once in a hospital stay for the patient, then how you will code the first services and subsequent services, like perform the next day. Like one day the consultation perform, second day the consultation perform. So how we will code that consultation? Answer: one line interview questions. When the same physicians or same specialty group physicians seen in the patient more than once during the same hospital stay, the first encounter is coded as an initial service and subsequent visit codes are using the subsequent care of codes. Like first day we are coding that the initial visit of consultation code, second day we are coding use the subsequent visit codes. See here, first services 992252 से लेके 99255 कोड फर्स्ट सर्विसेज, सब्सिक्वेंट सर्विसेज 992312 to 992331 code subsequent services. This is a very common inpatient ENM interview questions. Below the clear CPT and Medicare aligns the explanation of the rule and explanation exactly how interviewers expected. Scenario is given: same specialty group physicians see the patient more than once during the same hospital stay. Key role: only the first encounter can be coded as an initial, subsequent encounter are coded as a subsequent care. How to code this step by step? We'll learn that. First service: one day. If Medicare payer, that time initial hospital care 992212 to 99221 99223 code we are selecting there. If consultation code is not allowed by the Medicare, If commercial payer allow the consultation initial hospital care, we are using 99252 to 99255. In between we are using the codes. Subsequent services next day or later, both the Medicare and commercial, we are using subsequent hospital care code only, 99231 to 99233. So it will be showing that this is a second day consultation. Consultation code can't be used again during the same day, during the same stay. Why consultation codes are not used again? A consultation is a one time opinion or advice. Follow up the visit or the continue care. CPT code does not allow the repeat consultant by the same specialty for the same problem in a same admission. So comparison table, we have the first visit 9 Medicare or commercial we have there. So 99221 to 99223 and commercial 99252 to 99255. Second or follow-up visit we are using 99231 99233. In a second commercial also we are using follow-up rather than a consultation code 99231 to 99233. Repeat consultation allowed? No. Medicare also not allowed, commercial is also not allowed. Example here, Medicare patient first day consult cardiologist consult for the CHF code is 99223. Second day same consult cardiologist round again and they code 99232. Example, commercial consultation one day, nephrology consult for the AKI code is 99254. Second day same nephrologist follow up code is here 99231. So this way we are coding. Same specialty, same group rules. Physicians of the same specialty in the same groups are considered as a one physician for the coding. First day initial services, later or second day or next day subsequent hospital care. Common interview questions: can consultation code be billed again if the another doctor from the same specialty sees the patient next day? Answer is no, must use the subsequent hospital care code. Memory trick is there: first day initial, subsequent next day subsequent, same specialty same physician. Next question is here: how will you code the critical care services for the less than 30 minutes? Name name the few services which include the critical care services. Answer is also there, like a cardiac output measurement, chest x-ray, pulse oximetry, blood gases, EKG, gastric intubations, temporary. We'll discuss the each and everything. One line interview answer: how will explain that critical care services provided for less than 30 minutes are not separately reportable it, and should be reported using the appropriate ENM code. Many services such as cardiac output measurement, chest X-ray, pulse oximetry, blood gases, ECG, blood pressures monitoring, gastric intubation, temporary pacing, ventilator management, and vascular access are bundled into the critical care services and not separately reportable or billable. So how to code critical cares less than 30 minutes? We are not coding that. We use that what code? ENM codes. If more than 30 minutes we are using that 99291. So that code is will be there. What is the service included in critical care management? As I told, cardiac output measurement, x-rays, pulse oximetries, and like there cardiac output measurement, chest x-ray, pulse oximetry, blood gases, and their temporary transcutaneous and ventricular management, vascular access, these all are included in a critical care. Let's discuss into the detail. Below is the clear CPT based on the explanation of the critical care less than 30 minutes with the rules and include everything. We discussed that how to code critical care services less than 30 minutes. CPT rules very important. Critical care times of the less than 30 minutes on the given date not separately reportable. Why CPT definition critical care 99291 as a 30 to 70 minutes? The time below 30 minutes does not meet the threshold of time, right? So correct coding approach is: do not bill the 99291. Report the an appropriate ENM code instead of the like that ED ENM 99281 or 99285 depends upon the location. If the initial is hospital care 99221 to 99223, subsequent hospital care if there is 99231 to 99223. like that. Example here, physician provide 25 minutes critical care services hypertension patient in a ICU. Don't use that 99291 because time is given 25 minutes. Code appropriate code like 99223. Example is one like that, physician provide the ICU, the same is there. Example 2 is here like that, emergency physician provided 20-minute critical care. So example 9 and 2 at 5, high level of the visit, we are providing high level service include the critical cares management, not separate billables. When the provider during the critical care times following the services are bundle include the critical care 9 and 2 9 1 to 9 and 2 2. What is those cardiac output measurement, chest x-ray interpretations, pulse oximetry, blood gas interpretation, electrocardiogram, ECG, blood pressure monitoring, non-invasive gastric intubations, temporary transcutaneous pacings, ventilatory management, or vascular access like peripheral IV. These all are a part of the critical care, so we can't quote separately. These services cannot be built separately when these are the part of critical care. Examples of bundle services scenario, patient is a septic shock, physician provided the ventilator management, ABC ABZ interpretation, ECG in review, and central monitoring. So these all are a part of the critical cares. Code only 99291 only, not separately billable the ABC or ECG ventilator management. Key interview tables, we will see that situation or correct code. Critical care less than 30 minutes, regular ENM code only. Critical care more than 30 minutes, 99291. Supportive services during the CC bundled. Separative billing allowed? No. So memory trickle, what very important or very helpful, less than 30 minutes, no critical care code use. More than 30, less than, sorry, less than 30 minutes, no critical care we can use. More than 30 minutes critical care use. Supportive services bundle. Common question in interviews, can you bill critical care if total time is 25 minutes? No, must be build appropriate ENM service. Thank you for watching my like channels and subscribe for more. And code, you are watching coding with Kamal Yadav, please subscribe and like my channel. Thank you so much for watching.